Hello and welcome to the MIMS Learning Clinical Update podcast, the podcast that brings you thought-provoking clinical education that you can fit into your busy life. I'm Rhiannon Ashman, Deputy Editor of MIMS Learning, and we're a week out from Christmas. This is our final episode of 2024. We've got a special roundup today for you of our favourite guest interviews, learning tips and clinical insights from the podcast over the last 12 months. We've had some brilliant guests on the podcast this year and really interesting discussions on the key clinical areas affecting general practice. In this episode, you'll hear about health inequalities in cancer care, severe mental illness, how to support members of the LGBTQ+ community. We'll also hear clips from clinicians specialising in frailty and care of nursing home residents, and we'll finish off with some thoughts on rising cases of infectious disease seen earlier in the year and how to tackle the issue of vaccine hesitancy. A lot of ground to cover, so let's get started. The MIMS Learning editors have spent a lot of time over the last year working on our editorial campaign targeting health inequalities. Back in June at our MIMS Learning Live event, I asked Dr. Ravi Ramanathan, a GP in Ealing and MIMS Learning's clinical advisor on primary care, what the key learning needs are for GPs around health inequalities. Here's what he had to say.
I think the key learning need is understanding that significant inequalities exist, and then I suppose the challenge is to create mechanisms to reduce these inequalities. There are various small projects starting currently. For instance, in our area, we're trying to target Afro-Caribbean men who've not had their blood pressure checked because their blood pressure is significantly less than the rest of the population.
Why would that be?
I mean, the reasons are extremely complex, but if you look at the figures, it definitely exists, and then that has a knock-on effect for cardiovascular disease, stroke, and so on. So we can't change societal situations, but we can address these inequalities where we identify them.
So, as we alluded to at the end of that clip, our aim with this campaign was to inspire healthcare professionals to make their own contribution to narrowing inequalities by raising awareness and changing their practice. And we ended up publishing 20 learning modules that have been completed over 12,500 times. And because we think this issue is so important, all of the modules under this campaign are free until January the 6th. So please don't miss out. Take a look at them on our website, mimslearning.co.uk. You just need to register with your email address. There are lots of topics covered, from homelessness and prison healthcare to maternity care, lung disease, all sorts. And these clips coming up will give you a bit more of a taster. We focused a lot of the content for this health inequalities campaign around the priorities set out in NHS England's Core 20+5. One of the 5 clinical priorities is severe mental illness in adults. And earlier this year, Professor Carolyn Chew-Graham, who's a GP in Manchester and our clinical advisor for mental health, spoke to our medical editor, Dawn Liz Powell, about how to support people with severe mental illness in primary care. In this clip, you'll hear her talking about key areas to cover in a consultation with someone who may be experiencing worsening mental health.
It's more about taking a really good history, and obviously that's difficult in a 10-minute consultation, and it's often really difficult when we're doing online consultations or telephone consultations. But I think there are the 4 areas that the GP should be asking about in anybody with a mental health difficulty. So, functioning, cognition, what are you thinking? What's your mood like? And what's going on in your head? And so the sort of questions that I ask are things like, have you had any thoughts that are bothering you? Are there things that are happening that you can't explain? Do you think you might be seeing or hearing things that no one else is aware of? Have you felt lately that people are talking about you? So those sort of questions are quite broad, but they do allow people to disclose symptoms that they might have been worried about. They might be concerned that they're a bit silly, they don't want to talk about them, but you're asking an open question, and that helps people to disclose their concerns. It's also really important to ask about family history of severe mental illness, because there is a link, and again, particularly in bipolar disorder. And it's really vital to ask about drugs and alcohol. And then important to ask about self-harm behaviour and suicidal ideation. So we know that at the onset of a psychotic illness, people are really at risk of self-harm and suicide.
So, of course, we know that rates of mental illness are higher among the LGBTQ+ community. And this is something we touched on in an episode back in May when we considered the experience of trans people seeking healthcare. I want to take us back now to the very first episode of 2024 when MIMS learning editor Pat Anderson met Dr. Cisaru Sukumaran. He is also a GP in Ealing and he supports members of the LGBTQ+ community through his voluntary work with a service called Antidote, which is run by the LGBTQ+ charity London Friend. This service specifically supports people in the community who have drug and alcohol issues. In this clip, you'll hear him talking about why the people he speaks to might feel apprehensive about engaging with healthcare professionals and what can be done to make the experience more comfortable.
Do they find that there are gaps in clinical care for people from the community that mean it's difficult to access care or that they don't get the right care sometimes from the NHS?
I think it is worth saying, obviously everything I'm saying is anecdotal. A lot of it, I don't have any written evidence of a lot of these things, but from my experience, some of it personal as well, has to be said, and from the experience of friends and a lot of the clients, generally speaking, the NHS has improved in the way it deals with people from the community. I think even about 10 years ago, 15 years ago, there was still very much a feeling that certainly the clinical side of the NHS did not understand the community, and therefore there was an anxiety and a fear of going and speaking to someone and asking for help. That has improved significantly. But having said that, there are issues that the community often go through, and perhaps I could say it's often more gay men that seem to have this issue, particularly when it involves things like drugs and alcohol.
Right.
I think when it comes to alcohol and benzodiazepines and so on, there's a lot more established research, there's a lot more established help that is available. But when it comes to drugs such as crystal methamphetamine or TINA for short, GBL or ketamine or methadone, all of these, the usage is unfortunately prevalent. But there isn't any sort of structured help available. And also, a lot of clinicians may not actually know much about these drugs as well, because the average patient, and this isn't just restricted to the community, I think everyone wouldn't want to come and tell their GP, oh, I am taking crystal meth or I am taking methadone, because they know that it goes onto their notes. And there's an element of shame, there's an element of guilt, embarrassment, and the sheer fear that all this will get out to their employers and their families and so on. So there is a fear of sort of informing and revealing the information. And so when they come to an organization like us, we can actually help them. I don't know if there is a solution to that, in fairness, but at the same time, I think if a clinician is aware that, for example, crystal meth can cause dental problems if smoked too much, or that, ketamine can cause bladder problems if taken in excess, then they might be able to deal with it better if a patient tells them that there might be an issue there, and perhaps record things in a slightly less accusatory way in the notes. It's difficult, and I don't know if there's an answer to that, but I think it's more about awareness that this problem exists. And once that awareness increases, hopefully there will be more of I hate to say that, hopefully we will not need to see so many clients at London Friend and Antidote.
So you heard there Dr. Sukumaran talking about the need to raise awareness of specific issues affecting certain groups. And in this next clip that I'd like to share with you, Dr. Anthony Cunliffe, a GP and National Lead Medical Advisor for Macmillan, reinforces the message about understanding the issues that affect people's engagement with healthcare. Here he is speaking to Pat earlier this year on health inequalities pertaining to cancer diagnosis. Pat's just asked Dr. Cunliffe to comment on specific drivers of health inequalities and whether staff training or unconscious bias may play a role.
I think certainly as a GP in primary care, we might feel that we know the underrepresented groups in the population that we look after. So we might be aware of what maybe the ethnic diversity is or the deprivation levels are in our population, but we might not quite understand that the drivers that go behind the poorer outcomes for those groups. And I think one of the most important things is that we need to not only know what populations we serve, but the issues that those populations are facing that are impacting on their engagement, experience, and appreciation of healthcare. So I think there are multiple drivers, and again, we could probably talk all day about the drivers, but we've talked about data already. I've been able to highlight that there's a dearth of data around inequalities, although it is getting better, but so much more work needs to be done to ensure we get better data. An example might be people who identify as LGBTQIA+. We need so much more data on outcomes for those individuals. And obviously, a lot of that is based on routinely collected data. And if we're not routinely collecting that data, we're never going to understand the variation in outcomes for groups like that. Even ethnic diversity, we might feel that we're much better at collecting routine ethnicity data, but still, for a lot of data sources, we don't have the level of data that we need. So just data collection, and as GPs in primary care, we have a real responsibility there. We're looking after these people, and we need to make sure that we are collecting that data and coding it appropriately so that people aren't disadvantaged by that data not being collected. Discrimination, I think we can talk about discrimination, and some of it is unintentional, of course, and that might be down to lack of understanding, lack of knowledge of the particular potentially cultural needs of a certain group. So even though it might not be intentional discrimination, it still has a similar impact on the individuals concerned. However, we do know there probably is discrimination there that isn't necessarily unintentional. On certainly people will report experiencing it. Certainly older people, potentially people with learning or physical disabilities, LGBTQIA plus individuals, and people from different ethnic backgrounds as well will report that they feel discriminated against, which leads on to another one of the drivers that we could talk about, which is trust. If you feel that you are discriminated against, or you're worried about discriminated against, perhaps because somebody had a bad experience, then your trust in the system, your trust that you are going to be treated equally, your trust that your data is going to be treated fairly, can really have an impact on somebody's willingness and ability to engage with the system.
Later on in this interview, Dr. Cunliffe goes on to discuss practical things that GPs can do to tackle inequalities in cancer diagnosis, including reviewing the demographics of patient groups and targeting higher risk groups when it comes to disease prevention work, among other suggestions. So it's well worth listening to the full interview. On the topic of barriers to care, I had a great discussion with Dr. Mark Nelson all the way back in February. He's a consultant and professor of HIV medicine at Imperial College Medical School, and he's built a large HIV practice. We discussed the role of stigma as a barrier to patients with HIV accessing care and the importance of language around PrEP or pre-exposure prophylaxis. Dr. Nelson also made a fascinating observation about HIV and an ageing population. I'm imagining there are a lot of older people now who, having been on treatment, have survived longer than expected and are living with HIV. And I was also thinking about the people that you've mentioned from communities where they might already be facing stigma for a different reason. So the trans community, sex workers perhaps, who might have a diagnosis of HIV, but who also might experience stigma in other areas of their life. And I think, is that something for healthcare professionals to bear in mind?
I think what's important about access to care and different communities, it goes much further than HIV, and we've learned several lessons along the way in HIV. And certainly one of the groups I work with and I'm a trustee of is NAS, which has looked at ensuring good provision of HIV and sexual health care to members of minority population, Africans, Asians, etc. And what we've seen is the way forward is in some ways the job is done in HIV, but to move forward as regards other diseases. So we know in black communities that there is high rates of undiagnosed diabetes, hypertension, mental health, and you use the experience of talking to these populations and ensuring positive health outcomes, that we use that knowledge to actually drive forward better medical care in other aspects. I think the elderly population with HIV is interesting in that individuals living with HIV are now going to outlive those individuals not living with HIV. And the reason for that is because of all the screening that we do, looking for comorbidities, looking for heart disease, bone disease, liver disease, kidney disease, whilst that the non-HIV population has to wait for an event to actually happen before they often access care. So we're certainly going to see an ageing HIV population. And one of the issues with living with HIV, which is very pro-inflammatory, is that there may be an increased risk of frailty. So very important that we think about an ageing HIV population and what needs to be provided for them. But it becomes a difficult situation, I think, when actually we're providing better care to someone living with HIV to not living with HIV. And many years ago it was the HIV population outside saying, give us good care. Should it be the HIV negative population saying, I want the same care that any individual gets, that we should all be getting exactly the same care, which is what medicine should be about. So I think there is the idea that we will have an aging HIV population with specific needs, but we've got an aging population without HIV with exactly the same needs.
That's a fascinating concept that I hadn't thought about, that, the benefits to people's sort of other health outside of their HIV diagnosis. So you just heard there Dr. Nelson discussing the needs of an ageing population, and this is a topic that is raised time and again with us at MIMS Learning as a key aspect of the work of the GP. And as a team, we've become more aware this year that GPs have less and less time to spare on simpler, time-limited illnesses and are almost wholly focused on complex, often older patients who might have multiple comorbidities or maybe taking multiple medications. So back at MIMS Learning Live again in the summer, I caught up with one of our regular contributors, Dr. Pippin Singh, who works as a GP partner in Tyne and Wear. Here are his thoughts on the issue.
So I personally focus on a lot of diabetes. I'm the diabetic co-lead for my surgery. I'm the care home lead, so I deal with a lot of elderly, frail, institutionalised patients and also the diabetics, but take a big interest in men's health as well and men's sexual health.
What are the big clinical challenges that you're seeing at the moment in those areas? Like, what's been changing over the last few years?
I think one of the biggest things is obviously an ageing population, as I've just mentioned. That's putting a lot of demand on resource, and that is just only going to continue to grow, and we are still very restricted in the amount of appointment time we can give to patients. So we're still stuck at my surgery anyway with sort of the 10 to 12 minute patient appointments to try and just get through the demand. And as we all know as GPs, the volume of work has gone up, the complexity of the work has gone up. The 10 to 12 minute appointment time is just no longer fit for purpose. It was designed many moons ago when you probably could get through a lot more cases in that amount of time, which I think we're all struggling to do these days.
Shortly after that event, Pat spoke to Dr. Singh in more depth about how he manages the needs of nursing home residents that he looks after. In this interview, Dr. Singh gave a really good deep dive into a case study of an 84-year-old patient to illustrate the challenges and opportunities that he finds with this type of work. And on that point, here he is talking about continuity of care and why he finds it so beneficial.
I would say more than anything, we found that an individual clinician looking after the homes has reduced workflow throughout the week. It's improved continuity, so very rewarding for the patient, the clinician and the nursing home team within the home, who find it great to have a point of contact to go to, someone that they can trust and rely on. And you get to know them, they get to know you, and it makes for good working relationship. I also attend frailty meetings, so our PCN have quarterly frailty meetings, which I'm involved in setting up and setting the agenda for. And they're, as I've said, every quarter, and that involves the GPs within the PCN who look after care homes, but also our PCN pharmacists and also some of the wider MDT, which includes some of the nurses from the trust, safeguarding boards and so forth. So again, that can make for a very interesting meeting where you share cases in those meetings, interesting cases that have gone well, maybe not so well, learning points, and we often do some topic-based teaching within that. And we also invite a care of the elderly consultant from our local hospital to come along and provide some wisdom if needed also.
That's brilliant. I mean, I'm aware that frailty is coming up the agenda, and for primary care, thinking about frailty is increasingly important. But it's really interesting to hear that is being formally embodied in this at the PCN level.
Yes, yeah.
And would you think that, you might not feel equipped to say, but in other PCNs roundabout, do you think the same kind of thing is going on, or do you think yours is an exception?
Yeah, that's something, Pat, I'm not able to comment on. I don't know how other areas are doing it. I mean, it is part of the contract, so I suspect it will feature up and around the country, but how it will feature, I don't know. Some may be doing more, some may be doing a bit less, and that's like with a lot of general practice, isn't it? We're all quite different within our PCNs or within our ICBs as well. So I can't quite comment on how other areas are doing it, but if there isn't, if you're not, if you are listening to this and you're not doing that as a PCN, that might be something to think about. Could you have a frailty lead, someone who takes charge, attends frailty meetings, any workshops, any feedback that they're willing to provide to the wider team? Can you set up a meeting and so forth? Because it is often very rewarding and you do learn quite a lot from each other, I would say, doing that.
Those suggestions from Dr. Singh may have got you thinking about what you could do to streamline your processes around frailty. But let's take it back a step now and hear from another GP, Dr. Alistair Robertson. He has an extended role in frailty, and in a separate interview, he gave some tips on how and when you can identify frail patients in your practice.
If I'm a GP, when should I have frailty on my radar? What should I look out for?
Oh, it should always be on the radar. And it shouldn't just be the GPs. This is for everyone in the practice to look out for. Simple things, really, really simple things. Anyone, receptionists, nurses, pharmacists, social prescribers, anyone with any contact with patients or even just looking at their notes. So we talked a little bit earlier about Rockwood's model. There's another model out there by Fried. It's known as Fried's phenotype model. This has 5 characteristics which are very, very easy to spot.
Right.
So unintentional weight loss, self-reported tiredness, weakness measured by grip strength, reach out, squeeze my fingers, as simple as that.
Okay.
And walking speed and low physical activity. And out of all of those, it's considered that walking speed is probably the most sensitive one as well. So something as simple as watching a patient get up from their chair, walk across the waiting room towards a doctor's office, that alone could be a marker of frailty. And maybe just prompt somebody to say, we had a practice meeting the other day talking about frailty. This particular patient was very unsteady on their feet, getting up and across the waiting room. Things like that. That's something we could start doing today.
Okay. And if I wanted to be more proactive as a GP or a member of a team, are there tools that can help me to find the frail patients in my practice population? And
yes.
What are the limitations of these tools?
So, well, aside from those particular characteristics, you can look out for patients approaching end of life, nursing home residents, people who've been recently discharged.
Yeah.
Aside from that, you've also got your electronic frailty index,
Okay.
which is based on Rockwood's model. There's 36 potential deficits. When they're coded into your electronic record, the score will just sift through, add all of these up together and create your score. Pretty straightforward, from mild, moderate to severe. So you could analyse your database of your patients, search through it and search by the electronic frailty index, or EFI as it's known, and just start largest number to lowest number, take the top 20 or so and go, right, well, what do we do with them? And straight away you might go, well, actually they're all right, they're all right, they're all right. But you could identify very quickly a small cohort of patients right away without doing anything more than that.
Okay. That sounds really
There is one limitation to that, of course, though. As long as it's all coded.
Yes.
If it's not coded, it won't show up.
Yeah. So somebody has to have logged those aspects during a previous consultation.
Yeah, which is fine when it's things like atrial fibrillation, CKD, stuff like that. But there are other things, other deficits that maybe don't get coded. Things like the signs and symptoms, like falls, cognitive impairment, but particularly things like social isolation, mobility issues, being housebound, vision problems. These are sometimes things that kind of get lost a little bit.
In both of these interviews, Dr. Singh and Dr. Robertson go on to talk about practical steps to optimise care for frail older people, which might include looking at polypharmacy and whether medications can be rationalised, making best use of your practice team, and putting in place advanced care plans with patients and their families. If this is a growing issue that you're facing in your practice, I would definitely recommend a listen to these 2 interviews in full. And another quick clip that I wanted to share is Dawn talking to our clinical advisor for diabetes, Dr. Tom Crabtree. We know that diabetes can also make up a large portion of primary care workload, so it's interesting to consider how these two issues of frailty and diabetes intersect.
How does frailty affect diabetes?
So it may mostly affect the way that we think about setting targets and the sort of treatments that we use, because there may be some things that we would use in non-frail individuals that wouldn't be appropriate if someone was living with frailty. And that might be, for instance, insulin therapy. It may change the targets we use in terms of HbA1c. So that's really important to recognise. There may be specific things linked to frailty, so perhaps visual impairment, perhaps problems with continence, perhaps problems with mobility, that might then have a knock-on impact to certain things or the sort of things we provide or the additional support that might be needed. So if you take, for instance, someone who may have a degree of frailty and they have arthritis in their hands, they might not be able to give insulin injections themselves, for instance, and that might be something that we need to think about if we're going down that road. And if we need to go down that road, we need to think about what sort of extra support an individual might need in order to use those therapies.
Earlier this year, there was a lot in the news about rising cases of infectious diseases like measles and whooping cough. Back in the summer, our colleagues at GP Online reported on the rising cases of pertussis, 2,500 confirmed cases in England in May 2024 alone, compared with just over 850 cases throughout the whole of 2023. It seems that this was in part a result of declining vaccination uptake. So to circle back to the beginning of this episode, we know that there are inequalities in vaccine uptake associated with ethnicity, deprivation and geography. Our primary care professionals know that eligible patients should be encouraged to take up the vaccines available to them, but actually effecting this change is the challenge.
So I took the very simple approach of listening, and I wanted to make sure that they had their autonomy to be able to make their own decision rather than forcing anyone to take it, but making sure that they also had medical information.
This is Dr. Farzana Hussain. She's a GP in East London, and I talked to her about vaccine hesitancy around the time of the news of rising cases. Let's hear a bit more from her.
And I think one of my nicer stories was I had a patient who was 82 at the time, and my own mum would have been 82, but I lost my mum when I was 19, and I know her very well. And I said to her, what is your concern? She said, well, I'm really worried about it's a new drug. I'm worried about the long-term side effects. And because I know her, I giggled and I said, you're 82. If in 20 years' time you grow a second head, I'll chop it off for you, even though I'm not a surgeon. And we giggled about that, and it helped her get into perspective that actually her risk of getting COVID and, God forbid, dying was much higher than any potential side effect that could happen in 20 years. And because it's lovely to be a family GP and have a small list size, I said, my own mum isn't here. She died when she was 57, but if she was here, I would have wanted her to have it, and I'd like you to have it, even though you're not my mum. And her daughter rang the next week and said, I don't know what your doctor said, because I couldn't convince my mum to have it, but she went and had it. It made me remember the power of doctor-patient relationships and continuity.
So that story that Dr. Hussain told really stuck with me, and I thought it was a nice one for us to end today's episode on. And if any of these clips have whetted your appetite, don't forget you can listen to all of these interviews in full, plus the many others that we have via the podcasts tab on our website, mimslearning.co.uk, or on any podcast player. And you can of course claim CPD credits for doing so. We'll be back bright and early in the new year on the 1st of January with a special series of episodes introducing our new editorial campaign for 2025, supporting you in primary care with focused action to lead to earlier cancer diagnosis. So I'm wishing you a Merry Christmas and a Happy New Year from the MIMS Learning editors and our producer Till Owen. See you next time.